You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Hello and welcome to the final episode of Season 3 of the RN Mentor podcast. I am being joined by the incredible Dr. Adrienne Martinez-Hollingsworth. She is a Latina registered nurse, a health services researcher, and first-generation high school graduate. She is in her second year of postdoctoral training at the UCLA National Collision Scholars Program, where she has received NIH support for studies exploring the impact of provider burnout on diabetes care delivery among Latinx older adults in the safety net. Trained as a licensed vocational nurse at the East Los Angeles Occupational Center, she went on to receive her undergraduate degree in Women's Studies from UCLA, her Master's of Science in Nursing at Charles Drew University of Medicine and Science, and her doctorate from the School of Nursing at UCLA. She has worked as a clinician and administrator in large urban hospital systems and as a subject matter expert for technology companies. Dr. Martinez-Hollingsworth is a creator of Theory Generator Playground, a Latino Latinx student research collective that supports early career nurses by creating, facilitating service and research projects, mentorship activities, and college application support. It is her core belief that achieving health equity at the national level hinges on preparing the next generation of nurses from underrepresented minorities, including rural areas and immigrant populations, to meet the needs of a growing and diversifying population. Welcome to the show, Dr. Martinez-Hollingsworth.
Oh, thank you so much. Feel free to call me Adrian.
Thank you. I appreciate that. Now, you and I had met, it's been a while, 5, 6, 7 years ago, something like that. So it's been a while, and we met at a conference, at the WIN conference, I believe, if I'm not mistaken.
Yeah, I think we were in San Diego at the time.
Yes, definitely. So thanks for coming to the show. Thanks for staying connected. So let's start with, how did you get started in the world of nursing? Because you had gone a different route and came back to the world of nursing. So how did that begin?
Well, I have really done the entire career ladder in nursing. So I, as you mentioned, was a first generation high school grad, right? I didn't have a strong focus on education growing up. I had a wonderful supportive family, but they weren't really pushing women, especially, to go forward and get degrees. And so I had started working in hospitals as an unlicensed care provider, essentially what you would now describe as like a mental health worker or a CNA, but an unlicensed CNA. And so really just the constant support of nurses in these spaces is what continued to push me forward. I would be working with patients, really enjoying it. It's hard work. It's necessary work, but it's very hard work. And the RNs on the unit would be like, Adrian, what are you doing? You got to keep going back to school, keep getting more and more. And at the time, the East LA Occupational Center had an LVN program that was a shortened version. It was like 11 months. And, I got in there and I finished my LVN and got more exposure to nurses who were like, what are you doing? You can't stop here. This is a career ladder. And it was really their support that kept me looking for opportunities. I do have to say that I've been incredibly blessed with a lot of opportunities because there are very few Latinas in nursing, especially at the higher levels. So there were lots of scholarship opportunities and some key mentorship that I was able to access.
Yeah, that's fantastic. Now, what was your, I know you said like the sort of like the people that you were working with that got you involved in the nursing. How did you go about like actually saying, yeah, that's what I want to do? And where did you get like your start? Like what was your first step in that process? Or because I know, as you mentioned, there are like there's a lot of there's schools out there, there's opportunities out there, but they're not necessary. They wait for people to go to them,
Yeah.
right? So what was your first steps in trying to find those things out?
Honestly, I think the most important step to me was to understand what nurses are and who they are and what they do. Because I grew up, without medical insurance. I think I had Medi-Cal or whatever version we had back in the 70s. And I didn't have anyone in my family who'd been in the health professions at all, right? So
Right,
because of that, you think of nurses as people who change bedpans. You don't really realize the full complexity of what it means to be a nurse and
right.
all of the problem solving and all of the independence that you have in that role. And so, as a consequence, just hearing about what nurses do changed me. So I think the most important step really was just understanding what nurses do, getting that exposure. Because in reality, I didn't know anyone growing up who was a nurse. And I think a lot of times the media portrays nurses as less complex than they are and
Right.
less capable than they are. And so as soon as I actually saw that nurses had this independent hand, they were able to kind of problem solve for complex patients, and they were doing it all with this empathic, caring approach. I actually said to myself, wow, I'm a nurse. I didn't know. I wouldn't have known, but I've been this kind of person my whole life. And it makes sense to pursue this track.
That's amazing. Like I said, there's opportunities out there, but to get people to those opportunities seems to be the barrier, right? Like there is a perception, as you mentioned, of nursing, and even sometimes I even talk to nurses, and when I ask, like, oh, so how would you describe nursing? They default to the tasks that they perform
Yeah.
versus the actual work that is the profession of nursing, right? So I think there's definitely room for us as a profession to close those gaps and better inform the underrepresented populations in nursing as to what nursing does. So it's not just like a labor workforce type of a thing, but there's a
Mm-hmm.
whole profession behind it. So that's great. So how
Well,
did you, go
and
ahead,
can
go ahead.
I, yeah, and I think that the extra aspect here is that nursing requires a certain personality.
Oh yeah.
There's some variability in that. You need to be smart and dedicated and humble, but you also need to be an advocate. And
Yes.
so if you are somebody who's had challenges in life, or you have sometimes been called loud or bossy as a woman, right? Stuff like that, there is a space for you to really use those the dissatisfaction that you see with the world around you and channel that into better experiences for people.
Yeah,
So
definitely. Yeah, you mentioned that, and I laughed because my daughter, who is she's 12 now, but a couple of years ago, when she switched schools, she's like this person that likes to kind of get in there, take charge, and kind of move forward with whatever she's doing. And she got called bossy, and she came home and was like, "Why am I being called bossy?" And it wasn't that, but she's always had that personality. And for a while, that's just being called bossy kind of knocked her down a notch. And it took us a while to get her back to where she feels comfortable voicing her opinions and voicing, kind of trying to take a lead in a project that she feels passionate about. So there's definitely opportunities there for us to. That's a whole nother, I think, a segment.
I think it's unfortunate, but it is something that we need to talk about
Yeah.
because there is so much hierarchy in the field of nursing, and a lot of it is built on existing kind of sexism that we
Yep.
see in the healthcare field, and it creates unique challenges, especially for men wanting to get into the field.
Oh
Right?
yeah.
Like,
I mean,
where do they fit if our world is always seen as something that's kind of for helpers
yeah.
and for women? So yeah, no, there's a lot of conversation here, and it's really exciting that you do this show. I've been so impressed with it. So I'm just
Thank
so
you.
excited to talk to you.
Yeah, and I think part of the show and just making sure that there's I'd like to say it's not, some of the guests that I have on here are sort of not on purpose, but it's on purpose because I want to make sure that we're diversifying and we're bringing different aspects of the profession, and especially, from a concentration. I've been sort of I've been the show's been criticized, I should say, for the fact that I bring primarily nurses that have doctoral or master's degree and those types of things, but the whole purpose behind this show is not to necessarily just highlight those nurses, but show where nurses have opportunities, if that makes sense, right? Because there isn't representation out there. We don't hear that much about all the things that nursing does and how they advocate and how they're involved in policies and how they're involved in the political world, how they're advocating for communities. And so a lot of those nurses are nurses that do research and are engaged in those communities, on organizations and things like that, which I know you do a lot of work around. So, and we'll get into that. So what made you decide to go for your doctoral degree, and what was the, and then eventually a postdoc? What was the
Well, so
push for that?
I had gotten out of my master's program, and I was lucky enough to be offered a fairly lofty position that I probably wasn't ready for. But there's so few nurses with advanced degrees that you
Yes.
kind of get thrown into these spaces that, again, maybe you're not totally prepared. But I was the head of utilization, capitation, and case management for the children's hospitals in Southern California, which was a pretty big job. And it was based out of Rady, which is Children's Hospital San Diego, but I also supervised pods of nurses up in Orange County at Chalk. And so I was kind of traveling back and forth between these spaces, and I was helping establish policies and procedures for utilization. And, to simplify it, do people get the things that their provider requests for them, because they appear to be evidence-based, right?
Yep.
So there's a lot of power in that role, because you can deny something based on paperwork that in reality, in a very human term, is absolutely needed, right?
Yep.
But the paperwork and our systems don't necessarily reflect that. And so while I was there, I was trying to come up with algorithms to smooth that out, to make that whole process a little quicker. But I kept hitting this wall where there just wasn't enough scientific evidence for these sweeping decisions that we were making. And while I was at that job, I started kicking around the idea of, how do we generate research? How do we actually make this better? And kind of the breaking point for me was that I had a request for a cranial remodeling helmet, which is for, children sometimes who are born with cranial anomalies. They wear these helmets that protect them as they gently kind of remodel the skull. And so these are expensive devices. They have to be adjusted quite frequently. This was a while ago, and I would say that each visit, in order to have this adjustment made, cost about $2,000. So if you have multiple visits in a month, it's very costly. And so we were trying to find evidence to support this request. But it turned out that the child wasn't able to qualify because the skull measurement was off by like a quarter of an inch.
Wow.
And which is a lot in terms of skulls, but the problem is that I tracked it back. I thought, man, this family is going through so much. This is such a big decision for them. It's, and it's such an important aspect of this kid's development. And it turned out that our decision-making capacity was based on one study of 6 children in Denmark.
Oh, wow.
That was all the evidence that was being presented to support the policy. And, that, like I said, was kind of my breaking point. I was like, there's just no way. As a nurse, I'm trying to help people navigate this complicated and sometimes unfriendly and sometimes uncaring business that is healthcare. And this is one of those instances where a lack of good research is eating somebody up because it's a business, right? So that was it. That kind of prompted me to think about, well, how can I contribute to actually creating the knowledge? I knew people at UCLA, and they actually offered me entrance into this program to act as a bridge between my master's and my PhD. Because I'm sure it's hard to get in. It's hard to get in. It's hard to get funding, especially if you're not somebody who is, really excelled in college your entire life, right? You don't necessarily have the transcript that looks great. So this Bridges to the Doctorate program was incredibly supportive. And a lot of what they did was just meet with us and talk through our ideas, so that we could, kind of eloquently talk about what we're interested in. No, it was really helpful, and it set me on the path that I'm on today. And I'm really grateful that I got away from a corporate spot. I will say, as a researcher, you make less than half of what you make in these other positions.
Oh yeah.
And so I can see why for a lot of people it's very tempting to go directly there to decision making before you really understand the framework of how we're making these decisions.
Yeah, and I've had this discussion, I think, with several people, guests on my show, and just people in general that I've, colleagues, I should say, that had a hard time transitioning into, especially like academia, where a lot of research gets done, of the whole disparities in the pay differences, because prime example myself, going from service side to academia, I took a 50% pay cut to make that transition, which is painful, but but we do it for different reasons. So
it also kind of stresses your family, I think.
Oh yeah.
Because, I mean, obviously the financial stress is important to your family, but these are generally people that saw the sacrifice and dedication it took for you to become a nurse, right? I mean, anybody who is going into nursing, you have to expect that those first few years to get your RN at least, you don't really have a social life. You make tremendous sacrifices to be good enough and to process emotionally this entirely new world, right? So, and there's an expectation that there's a payoff, that nurses make good money. I mean, it is essentially a vocation. It's fairly blue collar. You can make a really good living and still afford to live in even big cities, but not necessarily if you're going to shift into academia. And that's a big problem.
Yeah, that is a huge problem. Yeah, because we're probably one of the only professions that allows us to make really good salaries from a associate's degree level on, except when you hit academia. Then it's like this, it's like sort of like a Monopoly game where you hit jail and you have to go back to the beginning or something like, right?
That's right. Don't go too far.
Do not go past, anyway, you almost get fined for being in academia sometimes.
You really do. And I think a lot of times it's because we haven't necessarily framed the return on investment for our communities and our world, right? Yeah. I think about, my husband came out of material science. He went to Caltech, and he does stuff kind of in that world. And the grants, how easy it is to get grants when you're talking about military research and that sort of thing, right? Like, there is just a different valuation. And I think we could do a lot better talking about how, it may look like I'm just doing patient-provider communication studies, but what I'm actually doing for you is giving you evidence to prevent all of these very expensive rehospitalizations. And so I think, if we could just get a little better at our framing, it might help.
Yeah. And I think, I understand from a lot of perspectives, academia is like, well, we're paying you according to whatever contracts or whatever agreements that they have. But I think for nursing specifically, just because we do put out so much, we put out the workforce, that's first and foremost, but we also put out a lot of evidence to be practiced in the community, in the hospitals, and all of that. So the fact that there aren't that many service academia partnerships as far as making sure that the faculty are being compensated so they are making money that's equivalent to the service side is a little bit shocking. I think there should be more investments from academia or from service side into academia from a salary perspective. I think there should be some people.
These roles exist, these jobs exist, but they're generally billed as chief medical officer. Right. And so that's the issue that I'm kind of confronting as a postdoc who has an operations background, but also has this, academic training. The jobs that actually fit my real description are reserved for physicians currently. And, and it's nothing personal. There just aren't many nurses who are doing this yet. It's a growing number, and we should be a growing number. But trying to convince people that nurses aren't the nurse that helped their mom when she was hospitalized for Alzheimer's, like, they really respect and care about that nurse. And so they, nurses are well respected and trusted, but it's difficult for people to make that mental shift and go, oh, but you can also be a CFO. Right. Or you can also actually, create and streamline all of these policies for us and build. So I tend to find the most traction in technology spaces. So I've worked for a number of tech companies because they generally have no concept of what doctors or nurses do anyway, right? They just know that you have some experience, creating systems, and that you have a clinical background, and so they're very welcoming. And but that's technology, right? We really need to make it much more mainstream if we're going to encourage people to go in this direction.
Yeah.
Because it's a hard sell. Hey, would you like to do an extra, 6 to 8 years of education and make half what you're making now?
Yeah. I've actually had people say, like, why would I do that? Right. And, it's hard to say, we have our own like intrinsic factors that kind of drive us towards, the higher degree or the research base. And there's a separate component that, like, for example, a couple of things kind of influenced me towards my PhD. One of them was the 2010 IOM report on the future of nursing. And I'm like, hey, that's something I want. And then the other component was I never wanted to be in a situation where I was qualified, but if you only had your doctoral degree, like that was exactly. I never wanted my degree to be the barrier that keeps me from moving forward. That was my big thing. Luckily my wife was supportive enough to let me do that when I did.
That's the key. That's the key issue, is supportive spouses.
Yes.
Right? And actually, I feel like that's one of the main challenges at the upper levels of kind of the top research universities, is that in order to do this kind of work, you have to have financial support. And traditionally that meant nurses who were married to doctors or other people that were making tons of money. So at all of these different universities I've been to, many of kind of the top people that have been there for a few decades, their husbands do something very important in medicine. And so this is just kind of a lark for them, right? Like they were smart people who just as easily could have done fundraising or something, but instead they chose nursing. And it can create this barrier between, people who are upper middle class / upper class versus the people who are coming in to do health disparities work. And they just don't have that cushion, right?
Right. So. And it's very true. And I want to say I'm almost hesitant to talk about it because I know some of those people, like, all of a sudden you see like this nurse who was in academia all of their life. And all of a sudden, like, they donate like $5 million.
Yeah.
I'm like, where did this $5 million come from? Oh, by the way, they are
my husband's the head of neurosurgery at Mayo. It's interesting, right? And I'm not knocking anybody.
No. I mean, I appreciate it because they're still giving back to the profession. But when we look at diversifying the upper echelon of nursing, when we look at diversifying with more underrepresented populations, some of those underrepresented populations are not coming from money. They are not married into money. They're not. They have to work to support not only their own family, but sometimes multi-generations.
Absolutely. Right? I worked full time through all of my education.
Yeah.
All of it, even the PhD, right? And I think about all of the opportunities I missed to attend other lectures and to go to dinners and all of these things that are great networking, but you just can't. You gotta, you gotta stay focused. Yeah, it's a big challenge. The biggest challenge that I'm facing lately is that I'm in these programs that are making huge efforts to diversify the field. And so they are making sure that they recruit diverse applicants, which generally means ethnic, racial minorities. Right. And I push this because I think we need to do a lot better, including rural populations, because that is a huge political power right now that we've kind of excluded to our detriment.
Right.
But the diversity that I see in my programs is of people of color who are upper class. Like these are people who are not first gen. They come from very wealthy backgrounds, and it's the same model that we just discussed. Like, yes, I'm a person of color, but my dad is the director of cancer research at, wherever. And my mom was the first epidemiologist to come out of it, right? Like, that sort of diversity is important because visibility is important.
Right.
But you're still going to miss some critical class-based discussions that are the foundation of health disparities in this country.
Right. Yeah, I 100% agree because, like, everybody has, from a research perspective, everybody has their own lens, and nursing specific, even if you look at it from a nursing lens, even within the nursing lens, we just based on our own backgrounds, we have different perspectives. So I think we shouldn't just look at skin color as the diversity of individuals, but we also need to look at the environment that they grew up in, because that's going to make a difference. If I grew up in a upper class or upper middle class versus I grew up in in a lower tier of income. So I think all of those are very valid points, which makes nursing overall complicated.
Yeah.
So thank you. Now I want to jump into and I want to almost kick myself for not knowing about your theory generator playground. What is I did my homework after you sent me your bio. I'm like, hey, I gotta look this up. So I want to talk about this because there's components of this that I kind of really speak to me. So talk about this theory generator playground.
Yeah, so it's a funny thing. I got a free computer through Hartford funding when I first started my PhD, and I called it Theory Generator. That was the name of my computer when you sign it up. And so that kind of, people are always like, what's the deal with the name? It doesn't say Latinx anything. And I was like, it was a spontaneous thing. So I started my PhD, and I, in that period, was looking at the experiences of older Latina women who had diabetes and obesity, and kind of what were their barriers to their engaging in physical activity. And so I was at UCLA, and lots of fantastic minds there. But at the time, and even now, there were no tenure track faculty that were Latinx. And that's kind of shocking to me, having grown up here in Los Angeles, because especially the neighborhoods that I've grown up, you've got like a 98% Hispanic Latino population. And so you would kind of think that there would be more representation of diversity. Not their fault, of course. Like I said, there's a small applicant pool. So, you're lucky to have who you have. But what that meant was that I experienced a lot of very unintentional, not malicious microaggressions, and they were pretty constant. And so some of the comments that I heard were just kind of big assumptions about who I was. And it was a lonely place, right? And so you're in a cohort, you're all competing for funding, you're all competing for recognition. It's a very challenging, rigorous academic environment. And I was getting to the point where I'd kind of had enough, and was seriously considering dropping the program, because it just felt like, there was no one for me to talk to and process anything. So I had met a couple of other nurses from other environments that were in academic programs, and we decided to start hanging out, for drinks. We'd go get wine and process the day. And it started kind of creating this idea in my mind of peer mentorship. And like, what does it do for me if I can go to a space and process some of these, like, microaggressions, right? Which were not maliciously meant, but are slowly chipping away at my desire to stay here. And so that's where it started. It ended up being a group of 5 of us initially, and we went and had dinner at Urban Plates, and then we just kind of kept going from there. And over the years, anytime we would get funding, we would invite each other onto our projects, so that you increase the number of publications, you increase the number of manuscripts, you get exposure. For most of them, there were only a couple that had PhDs already, or they were in the process of PhD, and most of them were looking to apply to their next place. And, getting access to active research, the ability to participate in research to build your CV, is challenging, and is often unfairly proportioned to the people who do have parents who are like the director of neurosurgery, right?
Right.
So that's what happened. And I started actually talking to kids as young as 8th grade and telling them, hey, if you're interested in healthcare, consider being a nurse. You've never heard probably about what nurses can do. So come sit in on our research meetings, and I'll teach you whatever little methodology I know, something, relatively simple, or I'll talk you through how to do a lit review if you have questions about stuff. And it just became this kind of ever expanding effort to loop in students. They could come from wherever. We did do like Latino focused issues. I sometimes use Latinx for kind of the broader appeal, but insiders generally don't like that. They generally feel like it's trying to, gentrify spaces that are kind of not comfortable. But
right.
Anyway, but yeah, so it grew from there. And I think today we've had like 18 people pass through this pipeline, because it's always about helping people get to that next step. So whether they're trying to get accepted from a community college into a top university, whether they're trying to go from their like master's to a PhD program, or they're trying to get through an NP program, we've had 100% success getting people to that next step. And it
Wow.
involves, writing each other letters of recommendation as we all become a little bit more like quote unquote important. Those letters have some more gravitas, right? But it's also just creating content for people who don't even have the ability to sit in on a meeting. So a lot of what I do is create YouTube videos and maintain that. And I have a Facebook page with lots of resources so people can look at scholarships. I help a lot of people with scholarship essays, right? I don't know why those are so intimidating, but they're so, many of them aren't even applied for,
Right.
right? And so yeah, it's been successful. It's helped me kind of keep my head above water in spaces that are not very diverse, and it makes me feel like there's some generativity that lets me breathe, because I know a lot of nurses who are in their like 70s and 80s who are not going to retire probably ever, because they never feel like they've made a big enough dent in
Right.
making things better. And we have to be able to retire, right? You have to be able to like do your time and then like step away, and and hopefully this will help with that.
Yeah, that's amazing. Now, I saw, and one of the things that caught my eye was the mural work that you did as part of this. Talk to us about what was. I've seen the YouTube videos, but I'm not gonna,
Yeah, no
without having
problem.
everybody go to your YouTube videos. And I will have actual links to your YouTube channel and Facebook and all that
Oh,
for
great.
anybody who's looking for it. But talk to us about what was your thought process around that and how it came to be. I have a love of art on the side. It's sort of like it's how I do my creative outlet. But talk to us about that.
Yeah, I mean, so there's a couple of explanations. Probably the first one being, if you try to sell, come to another class like environment to learn about research, that doesn't go very well, at least initially for people, right? It's not a big draw. And so what we do is a lot of service projects, and that can include like, beautifying the city type stuff where we do cleanup, or it can do things that are specifically, um, trying to improve an area that has some urban blight. And where I'm from, I grew up in Highland Park in Los Angeles, which was a pretty rough area in the 90s, and then suddenly started gentrifying. And now, I can't even afford to live there. But one of the saving graces was these beautiful murals that I grew up seeing. And they really do, I believe, make an area, give some of that, express that internal culture that's living inside the houses, in a visible way on the outside. Because you can talk down about a lot of communities, if you always have this kind of negative focus of what they're lacking. And I think it's important to have a positive, just kind of more optimistic outlook, recognizing the resilience that exists there. And so I think murals do that. In a deeper way, my mom ran away as a 14-year-old from a reservation in the Southwest and came out here to Los Angeles and made her way, at least initially, painting murals.
Oh wow.
And as a kid, we would go make extra money, painting like holiday signs on buildings. When it's like, happy, like Thanksgiving Day special, 99-cent hamburger, like that sort of thing, right? So I learned to not be scared of painting publicly and big, as a child. And then as I finished my undergrad, I had started working for a mural company. So again, it was an easy way to make money. I never considered myself an artist, but it's like, hey, this is a vocational skill I have. And this was before I started working in nursing. And I've done like 50 large scale mural projects in Southern California.
Wow.
And it was about that time that I was also working in a hospital, and I started on this track to nursing, and the murals had to sort of fall back a bit. But as I became a researcher and I thought about interventions in communities for my Latina women who have some barriers to exercise, I thought, of all of the murals that I've seen or worked on, not one has been health focused. Why is that? They're giant billboards advertising something, right? Like
Right.
sometimes they're portraying like, folklorico dancing, and like, wow, that's beautiful. But is there any real reason why we don't have something promoting breastfeeding? Like, is there any real reason we don't have something that's like allowing you to understand better what you can do to prevent diabetes? Like, why aren't we doing that?
Yeah.
And so my Albert Schweitzer Fellow project was using a mural to break down some of the barriers for these Latina women, to explore some of the barriers to public exercise in a community that, there are some social stigmas around taking time for yourself, frankly. And so that was the first mural project, and it's kind of gone from there. Our most recent ones have been in South LA, kind of the border of South LA and East LA, and we're working at a charter school there, trying to beautify some pretty hardcore urban blight for these kids, many of whom are fleeing unsafe environments because of gangs or because of trafficking or other things that they've been through, and don't deserve to go to school in a place that looks like a prison, right? So yeah, no, it's a very happy, pleasant part of my research work. Not the easiest to get funded, though. I will say that.
It's I think and I have to say I absolutely love this work that you're doing, because we I recently did like a sculptured piece around PPE, lack of
Oh
PPE
yeah,
over this
yeah, I saw
past
that.
year. We just had I just had a with partnership with the university I work at, with our I'll put their name out there, Cal State LA's library. Actually,
Mm-hmm.
we just did a virtual exhibit with nurses and physicians that do art, specifically, a little bit more specifically with around illustrations.
Mm-hmm.
But we kept it COVID focused. But there's a community of people in the healthcare field and in research that do just sort of what you're really talking about, using illustrations and paintings and art as a way of communicating to the masses
Mm-hmm.
uh, things that are related with what's going on in healthcare and health and well-being and all kinds of stuff. And the fact that we don't have, uh, as a profession, we don't give it more clout,
Yeah.
because it does reach a broader audience than a research paper,
Mm-hmm.
because we can reach the community. If I took your research and I put it on 10 sheets of paper and I published it and it ended up behind a paywall, the community is not going to get that. But if I
Exactly.
do take that same work and I display it in an art format, whether it's on a comic or whether it's in a sculpture or a mural or whatever the case may be, it's going to reach that much. The impact of that, I think, is so much larger than a published paper. Not to take anything from
No,
published
but
papers; they
I
have their
totally agree with
place.
you. Well, they have their place, but nurses are different than other scientists, and we really are tasked with changing people's hearts and minds
Yep.
and pivoting them towards positive, healthy options in a way that literally no other group is, because we do holistic care,
Right.
right? And so, yeah, you have to go with what's most effective, what's actually
Yeah.
going to help people process change. And then there's, like, weird capitalist barriers to getting access to this information, including these paywalls
Yeah.
that universities have to pay so much in order to get access to an article. And I had kind of a couple of months ago decided I was going to do everything I do open access from now on.
Yeah.
And just I had kind of averaged out my expected papers per year, and that would cost me $12,000 to $15,000 personally out of my grants and my personal funds,
Right.
just to make sure that the research that I create is actually seen by the people who participate in it. And that's shocking. It's not okay,
Yeah.
right?
Uh, and one of the things that I'm really happy to see, you're from the UC system, I'm from the Cal State system. One of the
Mhm.
things that both the UCs and the Cal States right now are pushing for is the information that they're generating go into open access.
Yeah.
I know the UCs sort of ended the whole relationship. We're going to pay millions up front to have access to our own research type
Hmm.
of a thing. And the Cal States have partnered right along with that, pushing for that open access for the research that academia is generating.
Hmm.
Again, like I said, I think there's a place for nursing journals or scientific journals overall. But I think as the creators of that knowledge, I think we need to do more in making sure it's accessible, and not, we pay or the grants pay for us to do the research. That research, we're almost forced to put it into journals
Yeah.
that, sometimes people have to pay to be
Yeah.
in those
Sometimes they have
journals,
to pay.
and then those same people have to pay to get access to those journals.
Hmm.
So there's a whole double dipping thing that happens with those journals that are making a lot of money off of knowledge that they are not helping fund.
No, it's true. But I also think there's this kind of larger disconnect because it's, you're right. Our progression in this field requires that we publish things,
Yeah,
right? And it that is kind of built in. But when UC was having their issues with Elsevier for a little while there,
right,
and we weren't able to access those journals, I wasn't able to access those journals in the 2 years that I was doing really important work, right? And that meant that there were certain perspectives, certain findings that I couldn't access.
right.
And that really hampers, I'm sure not just me, but science,
Yeah,
science with a capital S.
right,
And, the place for journals is this acknowledgement that I'm not doing documentaries here. I'm not doing my own personal spin. I don't get to do that, right? As a scientist, we're creating to the fund of knowledge for the species,
right,
not for my own glory. Because if you're doing it that way, you're doing it wrong, right? And I'm creating, basic information that people 2 generations from me can stand on top of and not have to start from scratch.
right.
The idea that a capitalist system is going to disrupt our species moving forward is something that I just take such umbrage against. Like, it is really challenging to me. In the same way that there's lots of people who will never use themselves, their minds, their hearts to their capacity because of student loan fear,
Right.
right? And so there's that part of me that believes that I owe what I'm capable of doing in terms of science to other fellow nurses who are doing their part on the floor, but I also owe it to them to be an advocate for the field and actually get out there and make sure that, like, silly capitalist leanings aren't the reason that they're able to really achieve what they want.
Right, right, 100% agree. And like I said, with I have some context for you. I think there's opportunities for us to collaborate
I'd love that.
on something bigger. So that's fantastic. Um, so I want to make sure that we're not running out of time. Thank you so much for this is all. I love the work that you do. I'm a huge fan. Anything else you want to share with us before we sign off?
I will just say that, my current focus right now is the impact of provider burnout on the delivery of quality chronic illness care in under-resourced settings like federally qualified health centers. But what I'm seeing in real time when I'm gathering data is nurses really suffering.
Mm,
And what we do is so important, even more so for the people on the floor than what I do. Please take care of yourselves. Guard your mental health like it is a crucial resource, because it is. And if you need access to somebody, make sure that you reach out. If that's a therapist, that's just a friend. Now is the time to make sure that we muster our resources and protect each other. So just be sure that you're here with us once we get through all this.
yeah, thank you so much. And just to piggyback off of that, the new Future of Nursing 2030 report had a huge emphasis on mental health well-being, and I think the profession there needs to be a movement that we are able to put out more mental health providers out there
Mhm.
for not only the profession but also just society in general. That was one of my biggest concerns with the pandemic, is like there's going to be a huge fallout.
Oh,
It
yes.
was like March of 2020 when this whole thing first started. One of the things I told my wife is nursing is going to suffer after this, because there isn't going to be, either people are going to leave the profession, or there's going to be some kind of a PTSD issue
That's right.
or some kind of a mental health impact in the healthcare overall. And I said, if we don't address this now, last year, we're going
Hmm.
to be behind the 8 ball moving forward. But I haven't seen a lot of movement from
No,
from the from the service side of taking care of frontline staff. There's some, but not enough.
yeah, no, you're 100% right. And I will say that a lot of this is rooted in nurses always deprioritizing themselves.
Yes.
That's a personality component of being a nurse. And it is time for us to make sure that we're taking care. Put your oxygen mask on first before you assist the
Yes.
child next to you, right? We got to get
Right.
that built into our culture.
Absolutely. Absolutely. You just gave me gave me a visual that's going to stick with me. I'm going to have to draw that out. So thank you so much for being here. I hope we continue to stay connected. Actually, I'm going to make sure I stay connected with you because I think there's work we can do together.
Yes, please.
So thank you so much for being here. We have been listening to Dr. Adrienne Martinez-Hollingsworth. I will have links to her and to her project. So please make sure you follow, and if you want to participate, I highly recommend it. And I look forward to what you're going to do next. With that, this is the last episode of season 3. I appreciate everybody's support, and thank you for being with us. And we'll be back at the end of July with season 4. Have a great one. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources. And don't forget to subscribe. Until next time, I wish you fair winds and following seas.